Dear Marrowlings, welcome to this Clinical Edge Live Plus session in which we are going to talk about hand-picked few psychiatry questions. These are some interesting questions which have been framed specifically by me to kind of teach you across some of the interesting aspects related to psychiatry. You might be an undergraduate studying psychiatry now, or curious about psychiatry, or somebody who's preparing for an entrance exam in full throttle. This next few minutes to an hour and a half would actually be quite interesting for you to learn a lot of aspects. In fact, some of it will make you remember some of the things you do on a daily basis. Let's jump into the first question, an interesting one for you. And I'm sure many of you would have faced such a kind of challenge. Father comes into the room and shouts and says, "Stop watching cricket, put off the TV and go and study." And this is something I guess all of us or majority of us would have heard. What happens next is also something we also would have reacted sometime or the other. You kind of get up and with frustration, bang the door and go into the room. Now, I know that most of us would have not studied that next half an hour, 1 hour, even though we would be so frustrated. It's the least we would want to do, right? Study. Now, the question here asked is, this is an example of what? Displacement or passive-aggressive behavior, projection, or sublimation. So which of the following defense mechanism is being given here as an example? You bang the door and walk in because you're frustrated, because your dad kind of spoke about asking you to put off the TV. Now, what is happening here? So let's talk about, in this example, the father has asked you to put off the TV and go and study. Now, there are different defenses which are given, right? Displacement, projection, passive-aggressive behavior, and sublimation. So what's actually happening here? Let's take up sublimation. Why have I highlighted sublimation a little differently? One of the important reasons is because sublimation is a mature defense mechanism. Which are the other mature defense mechanisms, if you could recall? Humor, anticipation, altruism, asceticism, sublimation, and suppression, right? In that is where sublimation comes. What is sublimation? Sublimation is basically expressing emotions and instincts in an acceptable way rather than a non-acceptable way. Let me give you a few seconds and make you kind of develop a scenario. In the same scenario, what do you think would be a sublimation kind of response? If a defense mechanism of sublimation was used by the boy or the child, what kind of response would have been there? Can anybody guess? I hope you kind of guessed it right. Like, for example, I'm frustrated that they ask me to go and study, but what I do is, instead of banging the door or getting frustrated and throwing things or something like that, in sublimation, what I do is I express the emotions in an acceptable way. So frustration is the emotion I have to express. So what I go and do is I go into the room and say, "Man, I'm going to get first rank," and come and throw this report card on their face and say, "Get lost." Now, what I'm doing here is I am going and aggressively studying hard and trying to crack the exam and get first rank or get kind of pass the exam or do whatever it is necessary. So here I'm channelizing my frustration into acceptable behavior. Obviously, parents, society, everybody else is going to be happy that I'm going to top the exam and show my frustration towards the studies and study more. Now, this also is that's why it's called as mature defense mechanism. Did you get the point? That's a simple example. Like that, there could be many other ways of mature defense mechanism. I'm just giving one example way of working towards it. So what is projection? Projection, if you look into, is a defense mechanism where you point at other people. You have flaws, but you point at other people. Now, for example, I'm frustrated and I say I'm frustrated because my father scolded me. I don't study. I go into the room and sleep off. And mom comes and asks, "Why are you sleeping?" I say, "Mom, dad scolded me, so I slept." Now, dad scolded you for some other reason, right? But you just say, dad scolded me, so I'm sleeping off. I'm not studying, I'm sleeping off. Now, this could be some kind of projection response. In projection, what you do is you project your emotions and flaws onto other people. Why did you tell bad words? He told bad words, so I told bad words. Why did you hit him? He hit me first, so I hit him first. A lot of kids do that, right? That's what is called as projection. A lot of our parents will tell us, don't point fingers at other people. When you point fingers at other people, one finger is pointing at them, three fingers are pointing at you. What they're trying to say is projection is not a mature defense mechanism, and that's what is projection in action. So, going on to the next defense, passive aggression, passive aggressive behavior. And I think we are all specialists in it also, right? Passive aggressive behavior. If you have really looked at this same example, how do you think a kid would show a passive aggressive response? A passive aggressive response is a response where you show indirect opposition. You don't oppose directly, you don't fight directly, but you kind of confront and oppose in a very indirect manner. So what you do is, they want you to go and study, and obviously they want you to go and study immediately. What do? That is the time you get out of the hall, but you don't go to the room immediately to study. You go to the restroom, then you ask, you take the pet for a walk, then you wash your face, then you change your clothes. You kind of postpone studying so much so that 1 hour, 2 hours go by, and your dad has to come and reprimand you again. Now, what you did was, you did not tell him anything. You did not kind of show aggression, nothing. You just very passively, aggressively kind of handled the scenario. And a lot of us are specialists in passive aggressive behavior. In fact, if you look at many a times, the reason we postpone studying is because we want to just not listen to them being told, like, you have to study. So you want to just push it, and that's a passive aggressive behavior which can happen. Is one way of expressing passive aggressive behavior. If you look at these defenses, there could be a little bit of overlap of things, because the definitions are clear cut, but in reality we don't live lives in clear cut manner. So there can be a little bit of overlap, there can always be confusions, but you need to know at least the gist of what these defenses mean. Coming to displacement, which is what we are talking about here. In displacement, what happens as a defense mechanism? Here you redirect your emotions onto something which is a neutral person or an object. So, for example, let's imagine I'm holding a water bottle in my hand. I'm holding a water bottle in my hand, and my dad tells me, Sunil, go and study, put off the TV. I obviously get frustrated with him. I can't go and hit him. I can't scold him, because I know I would not get the dinner tonight if I do that. So what do? I crush the bottle. I crush the bottle and kind of sometimes break the bottle. What did I do here? I showed my frustration onto something which is a non-living thing, or something which might not react on me. So, like for example, after a very bad day in office where boss yelled at me, I go back home, slam the door, or maybe I kind of sometimes yell at the kid for a small mistake which the kid did. So that's called as displacement. I show it on other neutral people or objects, and that is displacement, very commonly done by many of us. So these are all examples. Now, looking at this scenario, I guess you already know the answer, right? Slamming the door could be what? Displacement. Displacement is the defense mechanism we are talking about here. Now, with this understanding, I would also like to highlight, I'll go beyond my psychiatry and kind of tell you there's a life lesson for all of us, right? Next time you react, maybe you should pause and ask yourself, why did I react? Why did I get so upset with this person? Why did I get upset with my friend, partner, whoever it is? And most probably, if you pause and introspect, you might get reasons, and you might realize that you become a little more wiser with the reasons if you can apply and change. And who knows, you could change for better. So next time, pause, reflect, and potentially change for better reasons. So, moving on to the next interesting question framed for you. Here is a survivor of the 9/11 incident. The World Trade Center I guess you remember, right? Now, this guy survived through and is able to very clearly tell what he was wearing, what he was doing, what was happening at that time, what was the temperature on that day, what color dress was he wearing, what was he holding in his hand. He was able to give so much details of that particular incident. Now, can this happen, and what is it called as? This is an example of what? Iconic memory, implicit memory, autobiographical memory, or flash bulb memory. What do you think is the answer? I hope you have chosen the right answer, and the right answer is flash bulb memory. What is this flash bulb memory? Flash bulb memory is an extremely detailed and vivid recall of an emotionally charged event or a traumatic event many a times. Of course, it can be an happy event, but most of the times trauma is what we remember, right? So that is why flashbulb memory is something where you can give extremely high amount of detailing and vivid descriptions you can give about a particular traumatic or an emotionally charged event. Here, the 9/11 attack survivor, obviously it was an extremely charged event, and that is called as flashbulb memory. In which kind of scenario is it typically described to see flashbulb memory? We are talking about PTSD, post-traumatic stress disorder, is one of these scenarios where classically we are talking about flashbulb memory, or even you can see this in acute stress disorder. Post-traumatic stress disorder or acute stress disorder are two places where we might be describing about flash bulb memory. Getting it? A very interesting question which has also come in exams a few times. Talking about a few other important aspects here, we are talking about autobiographical memory. What is this autobiographical memory? Quite common sense, right? Autobiographical memory is nothing but memory of one's own experiences and events which are relevant to self. I mean, things which I remember and relevant to self. Now, the school I studied, the college I studied, the couple of close friends I had. I mean, if I had a crush, maybe if I can remember that and recall it. All those things are all called as autobiographical memory. Now, I have a question. Is flashbulb memory, which I described sometime before, part of autobiographical memory? What do you think it is? Is flashbulb memory part of autobiographical memory? Yes? No? I hope you have decided something. Answer is flashbulb memory is part of autobiographical memory. Obviously, right? Flashbulb is something which is extremely emotionally charged for you, so it's a part of your autobiographical memory. Now, implicit memory. What is implicit memory? The name itself says explicit, implicit. So what is implicit? Implicit is a non-declarative kind of memory, whereas in explicit memory, we can see the declarative forms of memory. Implicit is a non-declarative form of memory. You cannot say how you've learned or what you've learned. That's the problem with implicit memory. That's why it's called as non-declarative memory. It's devoid of a conscious effort. In fact, you don't choose to remember, but it just happens. And you many times don't know how you remember these things. That's what is the speciality of implicit memory, which is called as non-declarative memory. And the conscious effort is something which is lacking here. So types of implicit memory are, some of the important, interesting types of implicit memory are procedural memory, one of the important ones. When I'm telling about procedural memory, what comes to your mind? Swimming, cycling, driving, all of these are procedural memories, right? In fact, if you remember the initial few days you would have gone to your driving class, you'd be so upset if somebody talks to you or somebody, your phone rings or something like that, right? Because you're trying to concentrate so much and try to learn. In fact, if I ask you, how did you learn? It's very difficult to describe how did you end up learning, because that's the part. It's an unconscious process of learning which happens, and that's what is called as procedural learning. And the best part of procedural learning is once you've learned it, you have learned it. So 3 years later, 4 years later, even if you have not swum once or driven once, or through the lockdown you never took your car out, 3 months later or 2 months later, once you take the car out, you are able to drive almost the same way from the first beginning second. So that's the beauty of procedural memory. And literally, initially you are putting a lot of conscious effort to learn it through, but if you really see why did you learn, how did you learn, very difficult to say. That's why the conscious effort is lacking when you're trying to recall over a period of time. What about this Perceptual memory is an example of implicit memory. Things which fall on perception and perception system and sensory system, and you take in, right? All those things, perceptual memory is completely implicit, which happens. Priming is an important example of kind of implicit memory. What is priming we are talking about? We can be magicians use a lot of priming. Mentalists use a lot of priming. Like, for example, if I kind of say a simple example of priming could be is there are common shapes, right? We see in our world: circle, triangle, square, and those. Now, after a few minutes, I might ask you, okay, can you try to remember a three-sided figure? Most probably, you're going to remember triangle, because one triangle is the one which comes to our mind the moment we talk about three-sided. Moreover, I've also primed you by talking about some common shapes we see in the environment. So, priming something and asking the same thing could also mean a lot. Like, for example, magicians, what they do is they utter a particular country or a particular fruit, and later on when they ask you to remember, they give you something similar. So a lot of us will remember, like, for example, if I've uttered the country Dutch or Netherlands, most of the times their team color is little orange in color. If I ask you to remember a fruit, very likely that you might be primed by the Dutch and you might remember an orange fruit. That is where priming comes in, and these are all very less conscious effort based. That's why it is and difficult to say how do you remember these things, and that's why it's called as part of implicit memory. What about conditioning? Conditioning again is very implicit in nature, right? The pairing happens over a period of time and conditioning happens. Habituation, habits which get formed, is also a kind of implicit memory. Now, when you look into these aspects, you realize a lot of day-to-day life is about implicit memory. For example, a simple example of implicit memory is I might be telling you now, you should remember, this is the definition of implicit memory. They might ask you in exam. Now I'm telling you, they will ask you and you should remember, and in exam, you do remember that. That's called as explicit memory, because I've asked you to remember and you're able to remember. In the process, when you're trying to remember, you also remember, okay, Dr. Sunil that day was wearing a blue color shirt, maybe with this color tie. Now, if that comes to your mind, it's not something I asked you to remember, but because maybe you saw the video a few times to revise and recall, you kind of remembered the shirt, the tie, and those things. These are implicit learnings which can happen because of conditioning and habituation. So, can you understand if you are putting efforts to remember and recall, we are talking about explicit memory. When you are remembering things by not much of efforts, in a very subconscious process because of conditioning, habituation, priming, procedural and perceptual memory, then we are talking about implicit memory. So next time you can ask yourself, how many things do you remember because of your implicit memory? When you're talking about another life lesson here, right? When you're talking about doctors, have you seen so-called experienced doctors? What do they say? My gut feeling is this patient has something serious. I think we should look at it. And most probably, as an intern, you become quite surprised, or a PG graduate, you get surprised that when you do the blood test or an MRI or a CT, you really find something serious happening. And you wonder, how come this guy picked it up without even asking many questions? The reason is because that intuition is a part of your implicit memory system. Having seen so many patients over a period of time, because of the experience, they realize some red flags without even being aware what is that red flag sometimes. Now that's a skill you can build in if you can work in your wards more frequently. And if you're preparing for a multiple choice question, the more you answer MCQs, you're building in, okay, there's a red flag in this MCQ, this is how. So you can tune in and pick up many things much, much better. Here is an interesting question framed for you, where I is iconic memory, E is echoic memory. Statement 1 is I is an example of sensory memory. Statement 2 is E is an example of sensory memory. The question here is A, both the statements are true. B, both the statements are false. C is statement 1 is true and D is statement 2 is true. What do you think is the answer? Choose one among them. I hope you have chosen already, and I hope you have chosen the right one. Both statements are true. What are we talking about here? Iconic memory and echoic memory. These are topics which many times is not covered in a lot of our multiple choice question books, Q banks and areas. But very important for you to know, one, they can ask you questions. More importantly, it helps us to understand how a lot of things work in our brain. Now, what are we talking about here? We are talking about sensory memory. What is sensory memory? It's a very, very brief form of memory. In fact, sensory memory is the briefest form of memory you get. It is briefer than your immediate memory or working memory. It's briefer than your immediate memory or working memory. So what is this sensory memory? As the name itself says, sensory memory is something where it's a part of sensory memory, right? Perception happens. Now, for example, what happens here is, let's imagine perception can be visual, auditory, or touch. These are common perceptions which can happen, right? So, for example, if there is a stimuli, and let's imagine the light source there has to come and fall on my retina, right? So, this light source, when it comes and falls, that initial thing which comes and falls and the light is perceived, that's the visual sensory memory which happens. If somebody is calling my name, the sound waves travel and hits me, right? That's the auditory sensory memory which happens. The moment somebody touches me, there's a touch which is felt, right? That is the kind of touch-based memory which is coming in. Now, sensory memory is that initial thing which comes in, and it is very, 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 very brief. Why I'm saying it's very, very brief is because if I don't pay attention to it, it fades off and goes away. If I don't pay attention to it, it fades off and goes away. And it's important for it to fade off and go away because as I'm talking to you through this camera, thousands of things are happening around me. And there are lights, there are things happening, there are things changing. Now, if I keep getting distracted with everything and I start focusing, okay, what is he doing? Okay, what is the light saying? What is this happening? Okay, why is my phone ringing? If I'm going to give so much sensations, then automatically I'm going to get distracted and not complete one thing. So sensory memory is one which keeps picking up all the things which are happening, but not necessarily everything is going to be processed by the brain. Things on which attention ultimately is given and concentration happens are focused, rest are left away. So a lot of these things fade away, and sensory memory is one of the shortest form of memory which we need to understand. With this understanding, there are three important types of sensory memory we have. One is called as iconic memory. Iconic memory, and this is based on visual sensory system. The echoic memory is the auditory sensory system, and haptic memory is one which is based on touch, Now, how long? I said it's very brief, very brief, very brief. How long can it last? It can last maximum 1 to 2 seconds. Haptic memory, sometimes they say, can last a few more seconds, but most of the times it can last maximum about 1 to 2 seconds. In fact, iconic memory, when you are talking about, lasts less than a second. So that's how brief this sensory memory can be. Getting it? So it's important for you to understand the briefest form of memory we are talking about is called as sensory memory. Now, let me tell you an interesting example for you to understand the importance of sensory memory. So, for example, I'm talking to you. Now, I'm talking to you and I'm seriously involved in this conversation. In a few seconds, I feel, okay, somebody called my name. I turn back and say, did somebody call me outside? They say, yes, sir, they had called. Now, what had happened was, they had called me in a particular second. What happens is, I continue my conversation with you. Then I realize, oh my God, somebody called me. That part of time which the memory was held on is your sensory memory working there. It has happened many times, right? Like in a conversation, let's imagine I'm talking to my wife, and as I'm talking to her about something whom I met in a conference or something, I suddenly utter a girl's name. My wife goes on further and then she says, wait, what's the girl's name you said? So what happened is, We would have moved ahead in the conversation, but she comes back because the auditory memory, the echoic memory would have reminded, see, this guy is telling about some girl's name. Be careful. So she wants to check again. That's your echoic memory, which could be working. So these are small tuned things which happen in day to day, and it's good to know how our brains function. And sensory memory is one of the beauties of our brains functioning. So, in this question, what I've framed for you is, let's imagine a patient walks into a clinic which is kind of looking like this. And what happens when the patient walks into a consulting room or a clinic like this? He starts talking. He starts talking about the plants, the books, the things around in the clinic, what he can see through, right? And he's making quite an interesting speech. And what is happening? He also says is in very, very good mood. Now, his speech is an example of what? Is it tangential? Is it circumstantial? Is it flight of ideas or formal thought disorder? What do you think is the answer for this question? A very simple, interesting question asked to you. Answer is flight of ideas. Flight of ideas is the right answer. Why do you call it as flight of ideas, and what is flight of ideas? Now, flight of ideas is something which is typically seen in patients with mania. Mania patients typically have flight of ideas. What you see in them is they can be associated with pressurized speech. What is pressurized speech? Talk in a very fast manner that you don't understand. Did you understand anything? It's a very fast manner. So talking in a very fast manner that you might not even understand is what is called as pressurized speech. Like a pressure cooker, right? The pressure comes out pretty quick. So same way the speech happens. In flight of ideas, most of the times patients also could have clang association. So when they in flight of ideas, they jump from one idea to another, right? So they could have something called as clang association. What is clang association? They start using rhyming words. I'm going to America, drinka, binka, zinka, and minka. So all of these are rhyming words which don't even exist, right? So that's what is called as I'm going to America is something you understood. The other drinka, binka, zinkas, and minkas are all clang associations which you can get. Will all mania patients have this? Not necessary, but some of them could typically present like that. Environmental cues could be used to jump from one idea to another. In this example which I gave you, the moment he enters into the consulting room, he sees plants, he sees the pictures. So whatever is seen through he's talking about it. If he sees the AC, he talks about global warming. If he sees the lights, he's talking about sun or something like that. So whatever is in the environment is ideas are shifting from one to another. So that's how typically mania patients can present with flight of ideas. So in this question, we have also spoken about tangentiality and circumstantiality. Now, these are two terms which a lot of students do get confused. You should not get confused. First of all, tangentiality and circumstantiality is commonly seen in schizophrenia. But there is a small difference in what is tangentiality and what is circumstantiality. If you take, this is the normal thinking process or the speech process, what you need to understand is tangentiality, you deviate from the topic slowly, and you get away from the topic. That is what happens in patients with tangentiality. What about circumstantiality? In circumstantiality, you kind of beat around the bush, and come back to the topic. The difference between tangentiality and circumstantiality is, in tangentiality, you slowly deviate from the topic and go away, whereas in circumstantiality, you beat around the bush and come back to the topic. That is what is called as circumstantiality. The key word for you to remember is, in tangentiality, you typically see derailment. So what happens in circumstantiality? We are talking about unnecessary, boring details. Patient is talking in such an unnecessary, boring manner that you also sometimes can become drowsy when patients are talking about it. One single question, they talk about 20 odd minutes. So that's what happens in patients with circumstantiality, where they kind of give a lot of unnecessary, boring details. Getting it? So moving on to the next question, a simple question. Where do you use address test and what do you try to assess in address test? Now, of course, an address test can mean different things here. Now, the question here is, what is it trying to assess? Are you trying to assess orientation, memory, judgment, insight? What are you trying to assess by doing the address test? The right answer for this question is you're trying to assess for memory. Now, what is this address test we are talking about? Why is it assessment of memory? Address test is basically you are giving a 3 to 4 line address where you have a name and a house name or a number and a street name and a city name and the country name, something like that. 3 to 4 lines of address you give, and after some time you ask them to recall. You are seeing whether they were able to register the address, then recall the address at will. So that is what is called as assessing for recent memory. When you give enough few minutes and then ask them, you're checking for recent memory. That is where you use address test. Now, should you use address test? Not necessary. You can give 3 independent words and ask them to kind of recall it. That is also something you could do. In address test, you're giving a typical address, like say, for example, 108 St. John's Road, Sivan Chetty Garden, Bangalore 42. That's the address I would give. That's my address. And if I am going to give that address and ask the person to recall in a few minutes' time, we see whether they are able to recall. Now, if you're given enough time to rehearse and remember and ask them a few minutes later, most of us can register simple addresses and come back. Now, that is what is called as address test. Now, one of the reasons you don't use these things standardized is because an address which looks easy for me might be very difficult for somebody else. So we use typically the 3 items rather than an address test these days. Imagine you are asking a client for what is your current address you are in which address are you in, can you tell me where you are, in which floor you are, which city you are, which district you are, which country you are in. If I'm going to ask such kind of questions about your current address, so what do you think I'm checking here for? I'm checking here for both memory and orientation, because if I have to remember where I am now, I should remember when did I come to this place, which is this place, in which floor am I, all those things. So orientation and recent memory are checked when you are asking for the current address the person is in. So what do you learn from this slide? The thing you learn is it all depends on how you ask the question, because if you change the question and the words, you are assessing different things. And in neurology and psychiatry, you need to understand, right? Based on the question, the answer will be very different. So that is exactly why you need to understand there could be a little bit of overlap. When you're checking for orientation, some of it is also checking for memory. When you're checking for memory, some of it is also orientation based on the kind of words. So if I'm looking for current address, I'm also checking for orientation. But I'm just giving a 3-line address and say, can you recall it back? I'm just giving a test for its recent memory, the client's recent memory. Getting it? So in the same question, we have also spoken about judgment, right? How do you assess for judgment? When you're looking at judgment in MSc, right, you're looking at 3 levels of judgment. One is personal judgment, social judgment, and a test judgment. How do you assess for personal, social, and test judgment? When you're talking about judgment, you want to know the client's ability to judge personal level, social level, and a test judgment. A personal and a social one can be evaluated more by asking them history about how they plan to deal with the current scenario, future scenario, how do they plan to deal with their family, friends, and those things. So that might give you an idea whether they're able to judge their personal priorities rightly, wrong, or whether they are able to socially appropriately behave, think through what is needed, and take up the roles and responsibilities which they are supposed to be doing. What is a test judgment? In a test judgment, we kind of give the client a question and ask them how do they would behave in a particular scenario. One of the oldest questions we used to ask was, okay, you're walking on the street, you see an envelope with stamp, with the address, everything there. What would you do if you see the envelope when you're walking on the street? And you do have some time on leisure, so what would you do? Answer which we expect in many of them who are using normal judgment is, I will take the envelope, I'll see a post box and put it into the envelope, or if there's a post office, I'll hand it over and say somebody has dropped it and go. Now this is what we are typically supposed to do, but in today's generation we know very rarely letters are being sent, so this question becomes a little irrelevant. you might need to ask a relevant question to test the judgment. Okay, so that is what you need to do to assess judgment. A lot of times assessing judgment is a more complicated process. Through the interview you get an idea of how they think through, how they plan, how they are executing, how the level of judgment is happening. And judgment is something which is quite impaired in psychotics, whereas it is generally preserved in neurotic patients. Moving to next interesting question which is framed for you. Here is this child which is depicting the scenario very well. It is natural for children to say no, right? I mean, it's natural for children to say no. It is actually natural for children to say lies too. In which of the following conditions is saying no and stubbornness the core feature of the disorder? Core feature of the disorder. In which of the conditions is it? Is it ADHD? Is it ASPD? Is it ODD? Or is it CD? Which of the following is the right answer? The right answer is ODD. What does ODD stand for? ODD stands for oppositional defiant disorder. Oppositional defiant disorder. Now, what is a characteristic feature of oppositional defiant disorder? You should remember three important aspects which are characteristic features. Anger and irritability. These are very young children, less than 10 years of age most of the times, quite angry, quite irritable, and for small things they kind of get into temper and tantrums. So anger and irritability is quite high in them. They're argumentative and defiant. Don't go there, they go there. Don't touch that, they touch that. Eat this, they don't eat. Don't eat that, they eat. So that's what they're quite commonly going to do. Very argumentative, they're going to be quite defiant and those things. And very importantly, they could be quite vindictive in nature. Vindictive means they want to be revengeful, they want to be tit for tat, they want to give it back. So they can be quite violent sometimes to just give back their frustration and irritation. So vindictiveness could be very high in these children. Oppositional defiant disorder is typically seen in less than 10 years of age. Less than 10 years of age is where ODD is commonly seen, and the symptoms have to persist not for 1 day, 2 days or something. It should at least persist for 6 months or more. Then only we call it as ODD. Now, is it always seen less than 10 years of age? Most of the times it is seen less than 10 years of age. In fact, we know children as they grow might reduce their ODD behaviors. But there is a concept of adolescent onset ODD. What is this adolescent onset ODD we are talking about? As the name itself suggests, it is something where the ODD symptoms start off at adolescent age. At adolescent age. That is what is called as adolescent onset ODD. One of the interesting points you should know is about 1/3 of these children of ODD, right? 1/3 of the oppositional defiant children can go on to develop conduct disorder. Like 1/3 of the children can go on to develop conduct disorder, which is even more challenging scenario which can happen in some children. So what is the difference between ODD on one side and conduct disorder on the other side? ODD is generally typically diagnosed less than 10 years of age, whereas conduct disorder is generally diagnosed more than 10 years of age, less than 18 years of age. More than 10 years of age, less than 18 years of age is where conduct disorder is typically diagnosed. In ODD, you see the children having characteristically defiant behavior and disobedience. They are not obedient, they are disobedient, and they are quite defiant. What about conduct disorder children? Yes, they are also defiant and disobedient. Are they only that? Definitely not. They're a little bit more, right? What do? They're deceitful. What do you mean by deceitful? They tell lies, they steal, they cheat, they were manipulative, they do all those kind of stuff. Also, they are quite destructive. They destroy property. They destroy, sometimes they are destructive towards people, animals, and property. That's quite common in children who have conduct disorder, which might not be likely seen in ODD. So ODD is typically a little milder form, whereas conduct disorder is quite severe form of the condition you need to know. Getting it? These are quite common areas which is also tested in exams and good for you to know. Here is an image for you. What is being depicted in this image? What is happening in this image? Now, before I show you the choices, let's look at the image. What is this person doing? The person is looking at the weighing machine and thinking. And what is that they're thinking? It looks like they possibly are thinking they are too fat. In reality, if you really see, they don't seem to be fat. In fact, they seem to be quite fit enough, right? But they seem to be fat. They seem to be thinking that they are very fat. They are fit, but they think they are fat. Now, what is happening here? Now, is it anorexia nervosa? Is it binge eating disorder? Is it bulimia nervosa? Is it pica? Anybody would say it has nothing to do with pica, you'll remove it. So, out of the three, what do you think is the answer? Answer is anorexia nervosa. Answer is anorexia nervosa. What is this anorexia nervosa we're talking about? Typically, anorexia nervosa happens in early adolescence. It starts off in early adolescence. Binge eating disorder comes in young adults. Bulimia nervosa happens in late adolescence. So early adolescence is anorexia nervosa, late adolescence is bulimia nervosa, and binge eating disorder is in young adults. That's how you should remember for exams. There are two types of anorexia nervosa. One is called as the restrictive type of anorexia nervosa. Other one is called as the binge purge type of anorexia nervosa. Restrictive type of anorexia nervosa is where you restrict your food intake the whole day. You take very minimal calories. You eat half idli or quarter roti and you survive through the whole day. That is what is called as restrictive type of anorexia nervosa. Otherwise, you also have a binge purge type of anorexia nervosa where you see binge and purge patterns which can happen. Very important feature you should know is there is a significant weight reduction by at least 15% of the ideal body weight. If the person's ideal body weight is about 100 kgs, they should have lost at least 15 kgs for you to seriously think about anorexia nervosa. At least 15% of the ideal body weight should be typically lost in these patients. That's a very important feature we need to know. In terms of BMI, a BMI less than 18.5 is typically seen in anorexia nervosa. So if the BMI is normal or if the BMI is higher, it is unlikely to be anorexia nervosa. So when do you think of anorexia nervosa? When the BMI is going less than 18.5. The more it goes down, the more sure you are going to diagnose anorexia nervosa, and it is going to be a more severe form of anorexia nervosa. Amenorrhea, which was earlier considered as a very characteristic feature, we know is a very non-specific feature which can happen because of the hyperprolactinemia, which is quite commonly associated with anorexia nervosa patients. Lanugo hair. Now, lanugo hair is something which can be seen in anorexia nervosa patients. So it's good for you to know about lanugo hair being associated with anorexia nervosa, because in exam stress, right, you might not be able to link lanugo hair to anorexia nervosa, because why, you might wonder, why is lanugo hair going to be seen in a psychiatric condition? It can be seen is what you need to understand because of the dermatological epithelial cell changes and the hormonal changes. It leads to the presence of lanugo hair in anorexia nervosa. Getting it? One important interesting point you should know, they haven't asked in exams that much about this refeeding syndrome, but I would want you to know, because if you're going to be a good clinician, you should realize refeeding syndrome is an important challenge to deal with. Why? Because refeeding syndrome is something where we are responsible, not the patients. Patients have come with anorexia nervosa, they have starved themselves, and over enthusiastically I give calories and compensate for it. I say, okay, eat a lot, cheese burst, pizza, Coke, Pepsi, whatnot, give them a lot of calories, problem solved. No, you in fact increase the problems. Why? Because you're increasing the glucose intake suddenly, and once the glucose levels increase, you also know insulin is secreted a lot to kind of bring back the levels proper, and in that process it can lead to hypophosphatemia, hypokalemia, hypomagnesemia. And you know, hypophosphatemia, kalemia, magnesemia are dangerous combinations which can lead to cardiac arrhythmias and trouble. And you might sometimes even end up losing your patients because of the electrolyte imbalance, fluid imbalance, and arrhythmias which can be precipitated just because of over enthusiastic calorie compensation. Please understand, especially in the initial few days, you should do it in a graded, slow manner. You need to build up enough resources, give enough vitamin supplementation, monitor the fluid intake, monitor the electrolytes, and slowly build on, and then increase the calorie compensation. If not, we might unfortunately add more trouble to the patients rather than helping them. Refeeding syndrome, very important for you to remember. Please remember, it is the core features in refeeding syndrome is the hypophosphatemia, hypokalemia, and hypomagnesemia, which leads to cardiac arrhythmias and death in some of these individuals. So, in the next simple, interesting question, which I'm sure most of you will be able to answer, is which of the following therapies is used in clients who are preoccupied and anxious about contamination leading to excessive and repeated ritualistic washing? Each of these words have been carefully used for you to realize that when MCQs are framed, they might use any of these words: preoccupied, anxious, contamination, repeated ritualistic washing. Now, you know washing. What is ritualistic washing? Now, ritualistic washing could be is in OCD patients, right? They want to wash in a particular way. Like for example, WHO would say a surgeon has to wash in a particular way, right? Now, they'll give steps of washing so that the surgeons will ensure that infections don't spread. Now, that is what is recommended for surgeons, right? Typically, average human beings don't need to be really worrying about that level of washing every single time. But we have had patients who want to wash every single time at that level of washing. Now that is called as ritualistic washing. If they miss a step, they start washing the whole thing again and again. For them, if they have to wash 10 times, if they have rubbed 10 times, imagine they've rubbed only 5 times, or they have a doubt whether they have done 10 times or not, they will restart again. So that is called as ritualistic washing. When they use these kind of words, preoccupation, excessive, ritualistic, you know what they're talking about. Most probably they are talking about obsessive compulsive disorder. And what therapy do you think is the right one? HRT, EMDR, ERP, DBT. What do you think is the answer? The answer is ERP, exposure response prevention. Exposure response prevention. So what is this ERP we are talking about? We are talking about exposure response prevention, which is a very specific type of therapy used in patients with OCD, obsessive compulsive disorder. Understood? Now, it has two components. As the name itself suggests, the two components are, one is exposure component. And what is the exposure component? Here you have hierarchical exposure to triggers. Like for example, in a person who is worried about contamination, right? I might make him touch, let's imagine, a table surface. Now, table surface might not be that dirty. That's first level. Next level could be I might ask him to touch a floor. Maybe third level could be I might ask him to touch a shoe. Maybe fourth level could be ask him to touch the bottom of the shoe. Like that. This is a graded level of exposure or a hierarchical exposure of triggers I'm talking about. Now, that is called as exposure. You expose the person to anxiety-provoking situation. Not only that, here you also do is response prevention. What do? You deviate from their compulsive behavior or their regular behavior. Now, when there is contamination, or even when there is a thought of contamination, what do? They go and wash. Understood? When they have a doubt, they go and check. So you want to deviate them from that compulsive behavior. So you don't allow them to wash. That is called as response prevention. You don't allow them to go and check. That is called as response prevention. Did you get it? So that is what is exposure response prevention, where these two components of exposure and response prevention come together, and it's called as ERP, which is used in patients with OCD, obsessive compulsive disorder. The principles here used are habituation and the desensitization. By repeatedly exposing the person and preventing the response, right, you are slowly teaching them to get habituated to high levels of anxiety, and desensitized. You're teaching them to get desensitized and not get too worked up about their anxieties. That's the way this therapy works. Now imagine, after repeated sessions of making them touch very dirty surfaces and not immediately wash, what happens next time when they get a thought of contamination? Do you think they'll have so much anxiety? No, right? They've got used to dirt and those things, exposure and response prevention. So the thoughts might not lead to that much anxiety. And once thoughts don't lead to that much anxiety, their OCD gets cured to a better level. So that's how ERP works as a good treatment strategy in patients with OCD. The next interesting technique here we are talking about, and which was also given as a choice, was habit reversal technique. And where do you use habit reversal technique? Habit reversal technique is a behavioral treatment used in bodily focused repetitive behavior disorder. Where do you use it? In bodily focused repetitive behavior disorder. There are two specific disorders we are talking about here. One is the trichotillomania and dermatotillomania. What is this trichotillomania? Which that is nothing but compulsive hair pulling. And what is this dermatotillomania? Here we are talking about compulsive skin picking, compulsive hair pulling behaviors. These are examples of bodily focused repetitive behavior disorders. That's where HRT is used. It has 5 components. And what are the important 5 components of a habit reversal technique? One is awareness training. You basically make the person become aware of the premonitory sensation, the kind of sensations which come in their body, which makes them even go and act on the urge. So that awareness training is increased. You also teach them competing response training. In competing response training, instead of the hand going to the hairs and pulling the hairs, you teach them a competing response. Maybe hold on to the Rubik's cube and do the Rubik's cube, or hold on to a clay model and do clay modeling. Something like that, a competing response where the hand becomes occupied with something else. You also teach them to break these patterns. You also go through contingency management, relaxation techniques, and generalization technique. Means whatever small gains you have, you try to expand it to other levels. That is what is called as generalization training. So habit reversal technique is kind of useful in these patients with trichotillomania and excoriation disorder or compulsive skin picking disorder. Compulsive skin picking disorder or excoriation disorder, which is also called as dermatotillomania. Understood? What about EMDR, eye movement desensitization and reprocessing technique? EMDR is specific therapy used in PTSD patients. In patients with post-traumatic stress disorder, EMDR is typically used. Getting it? Now, there are important steps of EMDR. One important step you should do is, first of all, take a very detailed history to understand what kind of trauma, what kind of reactions the person are going through. And why do you think it's a post-traumatic stress disorder? You need to prepare the clients, because here when you expose them, right, they're already feeling very traumatized and stressed. So they might go through a lot more emotions. So they need to be little primed and understood that they need to understand there could be bouts of worsening, and they need to understand that they need to cooperate for a little duration for them to get better on the longer run. You should try to focus on the target memory. You should help them to process the memory in an adaptive resolution manner. So that is what is called as EMDR. Now, we all know when we share something painful with a few of your close friends, relatives who mean a lot to us, right? And when they are very supportive in their responses, we do feel little calmer and better. That is what happens in the desensitization processing. The eye movement is one way of kind of distracting you from the emotions, like asking the client to constantly have high movements when they're recalling these traumatic events, kind of brings the brain away from its emotions and kind of get into here and now. That is exactly what is done in eye movement desensitization and reprocessing technique, which is useful in patients with PTSD, post-traumatic stress disorder. Talking about dialectical behavioral therapy, Marsha Linehan is a person who developed dialectical behavioral therapy. Marsha Linehan, and for what condition? Borderline personality disorder or EUPD. What is EUPD called as? Emotionally unstable personality disorder. Emotionally unstable personality disorder is the condition where DBT is useful. There are 4 important components of DBT. The first component is mindfulness. Next component is emotional regulation. The third component is distress tolerance, and the fourth component is interpersonal effectiveness. Mindfulness, emotional regulation, distress tolerance, and interpersonal effectiveness. How do you remember all these 4? You can remember all the 4 components by remembering the acronym MEDI, M-E-D-I. M-E-D-I. Mindfulness, emotional regulation, distress tolerance, and interpersonal effectiveness, which are 4 important components in DBT, which is useful in patients with borderline personality disorder. Next is an interesting question framed specifically for you by me to kind of highlight an interesting area. What is the question? A man is a frequent consumer of alcohol. He reports of a scar on his face due to childhood accident. In reality, it was a road traffic accident about 2 years back in a blackout. He also has been having difficulty in learning new things in the recent times. His response to the facial scare is what? What is happening? Is it retrospective falsification? Is it approximate answers? Is it confabulation? Is it denial? What do you think the person is up to? Which of this is the answer? I hope you have chosen, and I hope you have chosen the right one. Answer is confabulation. Confabulation, if you carefully listen to the words in the question, there have been alcohol related problems. He has blackouts. Now he's coming up with some kind of memories which is not the reality. He's also having new learning problem, anterograde amnesia. So what are we talking about? We are talking about Korsakoff's psychosis. Korsakoff's psychosis is a chronic presentation which comes in, and these patients typically have confabulation, right? Confabulation. Filling up gaps in memory is confabulation. They also have anterograde amnesia as a common problem in Korsakoff's psychosis. In contrast to the chronic presentation of Korsakoff psychosis, you should know there is another acute emergency presentation, which is the condition we are talking about. We are talking about Wernicke's encephalopathy here. We are talking about Wernicke's encephalopathy. Please remember, Korsakoff psychosis is a chronic presentation, whereas Wernicke's encephalopathy is an acute emergency presentation where patients can have GOA, global confusion, ophthalmoplegia, and ataxia. Global confusion, ophthalmoplegia, and ataxia can typically happen in patients with Wernicke's encephalopathy. So, what is retrospective falsification? That was one of the keywords which was given in the MCQ, right? So what do you think is retrospective falsification? Retrospective falsification is an unconscious alteration or distortion. Okay, it's an unconscious alteration or distortion of the memories, and why this unconscious alteration happens? In order to kind of satisfy the present wish or need. I'm changing something of the past in order to feel comfortable or in sync with the current scenario. That is called as retrospective falsification. Now, to give you a real-time example, right, we do see patients who are quite depressed, and almost all the patients of depression will come and say their childhood has been bad, their parents have been troublesome, I've grown up in families which are quite challenging. It is agreeable that many families might have been pathological, there could have been challenges and situations. But we also know in the current emotional state, lot of what they evaluate in the past could also be very negative in nature. So there can be a lot of emotional retrospective falsification. For example, let's imagine I skipped a year and then got into medical school. Now, I might have chosen to get into medical school only, even though I would have got some engineering or something, I would have skipped one more year and done it. Now let's imagine as a postgraduate or as a medical doctor, I'm suffering a lot, I'm not able to settle down, I'm financially having challenges, I'm not able to successfully practice. At that time, I might realize, okay, a lot of other things have happened. At that time, people had forced me to do it. Maybe in reality, nobody would have forced you. You might have taken the choice, but retrospectively, things might appear falsified. That is where you need to be a little careful about how your current emotions might make you evaluate things of the past. So be careful about how you evaluate things, because sometimes your current moods can make you evaluate things very differently. You're too happy, you might take a lot more risks than what is required. You're too sad, you might avoid a lot of things where you should even actually give a try. So either ways, it could be a challenge. So be aware of retrospective falsification. It's a kind of hindsight bias which can happen. Moving next, it's a story of a lot of us, right? As a young doctor, you've been working for more than 24 hours straight, and it's right, you reach your duty room, and it's quite bright time now, and bright light room and you sleep off immediately once you reach your duty room. Which chemical could be the potential cause leading to this? Okay, so here is a daytime or a bright lit room where you kind of reach where you're exhausted because of your 24-hour long working time. What chemical could be leading you to sleep and become drowsy? Is it orexin, adenosine, melatonin, endorphin? Is it orexin, adenosine, melatonin, endorphin? I'm sure most of you would not even think of endorphin here, but you might have thought maybe of melatonin, but the right answer is adenosine. The right answer is adenosine. Please remember, if you were tempted to answer melatonin, answer is not melatonin, because melatonin is released in response to darkness. Here what they are talking about is a bright lit room, most probably daytime. So what they are trying to ask you is, when you're very much exhausted, being awake for a very long time, what is that chemical which could increase in your brain, which could make you sleep because you're been awake for a very long time? What is that which could constantly keep getting accumulated? That is where you need to know. We are talking about different types of sleep promoting agents, right? What are the important sleep promoting agents we are talking about? One is melatonin, which is typically released when darkness kicks in, right? That is what helps us to sleep. What about adenosine? Now, adenosine is the answer for this question. And please remember, in the basal forebrain area, right? In the basal forebrain areas, what happens is adenosine keeps getting accumulated through the day. In the morning, when you get up, you might have very minimal accumulation of adenosine. As the day goes on and goes on and goes on, as the hours of being awake increases, lot of adenosine keeps on getting accumulated. And this adenosine accumulation in the basal forebrain area is one of the factors which induces sleep in due course of time. And that is exactly why you use caffeine, which is an adenosine receptor antagonist. Why do you take caffeine to postpone sleep? The reason is because caffeine is an adenosine receptor antagonist, and that is where you need to understand adenosine is an important sleep promoting agent. GABA is an inhibitory substance. Galanin is a neuropeptide. They also are sleep promoting agents which you should know. So the important sleep promoting agents are melatonin, adenosine, GABA, and galanin. These are the important sleep promoting agents which you should know. Getting it? Now, what is orexin, by the way? Orexin is a wakefulness stabilizing kind of an agent. Orexin is a neuropeptide which is a wakefulness stabilizing kind of an agent. Understood? That's also something which you should know. Moving to the next question, which is a very interesting, simple question created for you. A game of peekaboo with members of the family is dealing with which of the following cognitive ability? In which of the cognitive abilities are we talking about peekaboo game happening? Peekaboo game happening in children is something which we see, right? Why would they do it? Now, please remember, we are talking about object permanence, object constancy, egocentrism, and volume conservation. Which of the following is the right answer? It is object permanence. Object permanence is the one which helps you to helps the kid to play the game peek-a-boo. Understood? Peek-a-boo game is linked with object permanence. Now, what is object permanence? What is object constancy? Please remember, object permanence is a very well-known concept which is described in cognitive development theory. When you're talking about cognitive development, Jean Piaget spoke about object permanence. It is typically developed around 6 to 12 months of age. When the child is about 6 to 12 months of age, you see object permanence being developed. In fact, these days we see children at 4-6 months itself having developed object permanence a lot. What is this object permanence? Here, the child understands the object is permanent. Even though it cannot see it, it still believes it is there. Like, for example, a child has not developed object permanence. So, if I'm showing a toy to the child, I'm showing the toy like this. So, suddenly I take off this toy and show an empty hand. The child will see the empty hand and think, what happened to the toy? It went away. So, the toy is no more. So, a child who has not developed object permanence, once the toy is taken away from sight, the child believes this toy is gone. That is what is lack of object permanence. Once the child is around 6 to 12 months of age, where they develop object permanence, what happens? You are showing the toy, suddenly you take off the toy, you show an empty hand. Even if you show an empty hand, they will know that the other hand might have it, or you might have kept it behind, so they'll search for it. They realize that, okay, this guy is cheating me, he still has the ball in his hand or the toy in his hand. So that is the concept of developing, okay, even though I cannot see it is still there, is what is called as object permanence, a very important cognitive goal in children between 6 to 12 months of age, which happens in the sensory motor stage of development. In sensory motor stage of development, you see the object permanence. What is this object constancy? Object constancy happens in something called as object relations theory or attachment theory. It is nothing to do with cognitive development, it is to do with attachment, the way people attach with each other. In that, object constancy comes. This concept of object constancy is supposed to have been described around 2 to 3 years of age. When people are around 2-3 years of age, they develop object constancy. What is this object constancy? Now, that is developed when you realize somebody who is leaving you and going will still come back and pick you up. Like a simple thing is, let's imagine I'm a very young child who's been taken to play school and left by the mother. Initially, when my mother leaves me in the school and goes away, right, I get very angry at my mother. I feel, oh my God, my mom is very bad. She's left me and gone. How can she do this? Will she come back ever? She might not come back, and those kind of things. After a few days, I slowly realize, yes, my mom will leave me. Yes, my mom will come back. Yes, my mom will pick me up. So that is what is called as object constancy. You kind of develop and realize that people can remain there, even though people might do things. Like, for example, I might not want to be left, but my mother is going to leave me and go. But at the same time, the same mother is going to come back and pick me up and kind of be nice to me. So slowly you develop the concept of object constancy. If you're not able to develop object constancy, use your common sense, you'll realize attachment becomes an issue. So that is where separation anxiety can happen. Separation anxiety can happen with problems in object constancy. Getting it? So next important thing is the term egocentrism. What is egocentrism? Egocentrism means I am very bothered about my own self and my own needs. I am not bothered about anybody else's viewpoints. Young kids are like that, right? For example, if I go and tell my young child, see, there's a lot of difficulty, there is recession, I have no money, I can't buy toys, the child will listen to me and then say, Papa, what did you buy for me? I say, Beta, that is what I'm saying. I have no money, difficulty. Okay, Papa, what are we buying today? Which movie shall we go? Shall we eat popcorn? The child is not going to be bothered about what we go through. The reason is not because the child is bad, just because the child might have not developed the concept. The child might be still egocentric. The child is looking at its own self. It is not able to understand, okay, the other people and their views also matter. It is important to understand others' views. The child is egocentric, so you're still stuck with your own self. That is egocentrism. What is volume conservation? When you're talking about volume conservation, as the name itself suggests, volume conservation is nothing but here you believe the volumes are conserved. For example, if I have a chocolate, understood, a very small child, you can easily play around, because if you take a chocolate and make it into 10 small pieces, they feel the chocolate, there are many pieces of chocolate. There's a lot of chocolate. But actually it was the same big chocolate which was cut into so many pieces, right? So a child who develops volume conservation, you cannot cheat them like that. They realize that, okay, this guy is acting too smart. He's taking the same chocolate and cutting into multiple pieces and giving it to me. So a child who has not developed volume conservation, you can kind of play a fool with them. But a child who has developed volume conservation, you cannot play a fool with them. So this is also described by Jean Piaget in his cognitive development theory. So you need to understand volume conservation typically happens in a stage called as concrete operational stage. In concrete operational stage, volume conservation process typically happens. Now, since we are talking about children, let me go on to another interesting MCQ created for you specifically. Here is a beautifully looking teddy bear which I'm showing you. And what is happening with this child? The child has been left over to stay in grandparents' house. Okay, quite common scenario, right? The child is left in grandparents. The child insists to carry the favorite teddy bear doll and felt comfort with the same. This is an example of what? This is an example of what? I am sure a lot of us would have done this, right? It need not be a teddy bear toy. It would be something else. It could be a blanket. It could be a pillow. It could be a dress. It could be kerchief. It could be various things. But what is it we are talking about? Are we talking about artificialism? Are we talking about animism? Are we talking about symbolic play? Are we talking about transitional object? I guess you answered it right. Answer is transitional object. Now, what is a transitional object? A transitional object is something which gives me comfort, comfort or support in transitionary times or difficult times or challenging times or changing times. So that's where the toy, the bed sheet, the pillow, those things could matter a lot. So it's not just a teddy with which I play, but the teddy could mean a lot of security for me, comfort for me, and that is what is called as a transitional object. A lot of us will obviously grow out of transitional objects, but some of us, even as adults, could have transitional objects. What is this animism? Now, animism is a concept described by Jean Piaget when he was talking about cognitive development, and those. Animism was a concept which was described. What is this animism? Animism is a state where the child who's growing up sees non-living things. Let's imagine there are pieces of stones and rocks. The child believes they also can understand, and the child is talking to the rock saying, oh, don't shake, okay, don't fall down, you have to stand there only. The child is telling stones or the rock or some non-living things and talking to it as if that has life. Now, we know that they don't have life and agency of themselves. They don't have willpower, agency, those things, right? But the child believes they also have their own thinking process and those. That is exactly what is called as animism. What is this artificialism? I'm sure if you have studied in English medium schools, one of the rhymes you would have been taught is rain, rain, go away, right? Now, do you remember that? Rain, rain, go away. Now, why should rain go away just because you ask rain to go away? That is because as you're growing up, you might have this thought process of something called as artificialism. What is artificialism? In artificialism, you believe that some natural happening processes, you believe is not just natural random processes. You believe somebody is controlling it and somebody is making it happen, and you think somebody's agency or willpower, and it is under the influence of something. So that is why you're asking it to change. That is what is called as artificialism. What is symbolic play? What is symbolic play? I've shown you pillows here. I still remember very, very well that when I was young, right, the bed was my bus. The front of the bed was my driving seat, and behind were 10 passengers. Who are those 10 passengers? 10 different pillows. And I am serious about those pillows. If the passenger has to go down, I used to take the pillow and throw out of the bed. Now that's symbolic play. For me, those pillows were just not pillows, but those pillows were human beings, my passengers. So that is what is called a symbolic play. When I'm telling all these things, I'm sure we are all touched to remember some of the past things we have done. Like as we grow up, we kind of realize that, okay, these things don't happen, and we move on. Sometimes it's good to realize why we did what we did, and this is why I think this MCQ kind of teaches you a lot of interesting aspects of how our psychological brain works. Going to next interesting question framed for you. Otherwise healthy 7-year-old boy presents to the pediatrician with history of bedwetting. Now, what is happening here is having 3 to 4 nights per week for the last 6 months, bedwetting happening. They've ruled out other kind of urinary tract infections, daytime incontinence, and other problems. Now, what is the next step you need to do? Should you prescribe a bedwetting alarm? Should you go for a renal ultrasound or any other investigations and those things? Should you try a desmopressin trial? Should you give any other medications? Or you should educate about healthy voiding practices? What do you need to kind of do now? Now, please understand, what are we talking about here? We are talking about nocturnal enuresis or bedwetting, right? Now, in those kind of scenarios, we need to remember the first step to do is to reassure and educate about healthy voiding practices. You have to educate about healthy voiding practices first. That's the most important step. We have to speak about reassure and educate about healthy voiding practices. Now, with this understanding, let's understand a little bit about elimination disorder. What are we talking about in elimination disorder? We are talking about encopresis and enuresis. Encopresis and enuresis. Please understand, encopresis is soiling of clothes by feces, whereas enuresis is wetting by urination. So, encopresis is diagnosed in children who are more than 4 years of age. Enuresis is diagnosed in children who are more than 5 years of age. That's an important point. Can be asked in exam. Encopresis 4 plus, whereas enuresis 5 plus age. I am sure you know this mathematical calculation, right? 2 plus 3 is equal to 5. Why am I telling about this when you are talking about enuresis? Answer is, for you to diagnose enuresis, the child has to be more than 5 years of age. What does this 2 plus 3 mean? The child should have at least 2 bouts of bedwetting per week for at least 3 months duration. Then only you diagnose it as enuresis. So for you to diagnose it as a significant enuresis problem, 2 times per week they should have bedwetting for at least 3 months duration, and then you diagnose it as enuresis. More important criteria, age of the child should be 5 and above. Okay, 5 and above, then only you diagnose it. Enuresis, the first thing you should do is to look whether it's a primary enuresis or a secondary enuresis, and obviously you should rule out organicity. For you to understand whether it's a secondary enuresis, if a child has not been wetting for at least 6 months duration, and then again they start wetting, that is called as secondary enuresis. If the child is not wetting for at least 6 months duration, now restarts wetting, that's called as secondary enuresis. One of the reasons for secondary enuresis is emotional problems, sexual abuse, physical abuse, domestic violence. When child goes through emotional trauma, they might regress and get into secondary enuresis problem. Most of the times, rather almost all the times, you need to understand these are self-limiting. It kind of gets better with due course of time. But please understand, it's important to equip the parents to deal with this scenario better. Otherwise, you might lead to a lot of emotional trauma in the child. By bullying them, by teasing them, by scolding them repeatedly, things can only get worse. So one of the aim we have is to avoid secondary emotional trauma in the growing child because of this problem. So psychoeducation is an important step in this process. Once enough psychoeducation is done, still if the child has continuous problems, then you can consider other treatments like alarm therapy, star charting and behavioral modifications, and of course desmopressin is one of the drug of choice considered in this scenario. Getting it? Moving to a very simple question which can be asked in exams is, what percentage of disability is considered as a benchmark disability? Okay, what percentage of disability is called as benchmark disability? Now, 20%, 40%, 60, 80%. What do you think is the answer? The answer for this benchmark disability is 40%. Now, which act are we talking about here? We are talking about an act called Rights of Persons with Disabilities Act. Rights of Persons with Disabilities Act. Okay. So what are we talking about here? We are, in this act, about 21 conditions come under the disability benefit. The earlier act, National Disability Act, covered about only 7 conditions. Now, luckily, a lot more conditions are being considered under disability benefit. Now, as per this act, 40% disability should be there for you to say benchmark disability, which means they get all the act's benefits. Understood? Now, mental illness, intellectual developmental disorder, autism spectrum disorder, and specific learning disorder are the four important things which are related to psychiatry, which comes under this RPWD Act. What are the important ones? One is mental illness, intellectual developmental disorder. The old term for it is mental retardation, right? So that term has been removed. Now you need to understand intellectual developmental disorder, mental illness, autism spectrum disorder, and specific learning disorder are the important aspects which are covered. So good to know about RPWD. Especially you should read up on the other conditions which have been included in it, like acid attack victims, dwarfism, thalassemia, sickle cell anemia, hemophilia. These are all conditions which are included in it. So read up on it, because you might not just get this question in psychiatry, you can get it in other areas of medicine also. Let's move to the next important question. The risk of suicide is lesser in which of the following individuals? I've given a list of individuals. In which of the following individuals is the risk of suicide less? Female gender patients. How about individuals with mental illness, individuals with cancer diagnosis, and elderly individuals? What do you think is the answer? Who has lesser risk? Elderly, females, mental illness, or cancer patients? So what do you think is the answer? Female gender is known to have lesser risk compared to the others which are given here. Now, what are the important risk factors you need to know? So talking about suicide, what do we need to know? About 11.3 suicides happen per lakh population in our country. Now, this is the latest reports where it is 11.3. The previous report, the NCRB report, said it was 10.3. Can you imagine a 1 point increase in the suicide rate? Which is unfortunate, right? And obviously to COVID and complications and challenges around it, maybe that is what has led to this increase in 1 point of the suicide rate, which is currently 11.3 suicides per lakh population. Now, about 1,60,000 plus suicides get reported in our country per year, and one suicide is happening every 4 minutes in India. One suicide is happening every 4 minutes in India. Globally, if you look at, it is about one suicide every 40 seconds. Globally, if you look at, it's about one suicide every 40 seconds. The important other point you need to know is we are talking about suicides here. If you're looking at suicide attempts or people are attempting to end their lives, right, it is 10 to 20 times or sometimes even say 25 times higher than this number. So if one suicide is happening, 10 to 25 people are attempting to end their life. And that is one of the reasons why when you're working in your casualties, you will invariably see a suicide attempt person coming into your casualty almost every day or every alternate day. So depending on where you are working. So the reason is because suicide attempts are even more higher, 10 to 25 times much higher than the suicides which happen. Now, male is to female ratio of completed suicide is in the range of 2:1. That is, 2 male suicides happen for every female suicide. Now, this is what is world over statistics. The unfortunate bad news is in India, the number of female suicides, especially young female suicides, is pretty high, and this difference is not that much, which basically means if you are a young female, one of the countries where you're more prone for suicide is India. And it could be having its own cultural reasons, social reasons, and those. Otherwise, generally, male is to female ratio is 2:1 world over. Important to understand, suicide is something which can have a bimodal representation. A bimodal representation, one peak happens in the adolescent and young adults, and the other peak happens in the elderly age group. Now, that is why you should understand elderly people do have high risk of suicide. And today, people live much longer, right? People live much longer, and if they get into, and we also know late onset depression and those things are quite prominent. Even dementia changes happen as a part of the elderly age group. They might also be prone for risk of suicide as much as young and adolescent people. So that's why we call it as a bimodal representation. Both have very high risk. The adolescent and young people as well as the elderly people both have high risk. What about hopelessness? Hopelessness is an important risk factor for suicide. Please understand, one of the important risk factors for suicide is hopelessness. Now, should you ask patients about suicidal risk and those, even if they're not talking about it? Anyone who is distressed, you should definitely ask about whether they are feeling suicidal, asking in a very normalizing question manner. Normalizing question manner could be something like this: I understand you're going through a lot of stress, and it looks to me that you're quite stressed. I also understand when people are very stressed, they do think of some extreme things. Is there anything like that happening? Now, asking about it is very important, because if they do say that they are suicidal, maybe you can help a lot more. Maybe you can be involved a lot more. Maybe you can support them a lot more, because otherwise we might end up losing these people. A lot of students believe that by asking, you might implant suicidal thoughts in their head. Definitely, you are not going to implant by asking them. Yes, maybe you should not ask very leading kind of questions, but if you're asking a normalizing question, it always helps, because you can tap suicidal thoughts and potentially help these people, and that's what they need. Past attempt is one of the most important predictors of future attempt. Past attempt of suicide is one of the most important predictors of future attempts of suicide. The more severe the past attempt, the more risk of the future attempt turning out to be lethal. Understood? Access to means and methods is an important risk factor for suicide. Now, this is unfortunate reason why a lot of doctors are having high risk of suicide, because they do have access to lethal means and methods. They know how to succumb to suicide. They do have sometimes those dangerous medications and those things accessible with them, so which makes it high risk of suicide. Farmers, for that matter, right? Farmers don't need to go and buy insecticides and pesticides. Many times they have access of it right in their own house. So those are the reasons why, unfortunately, they might be more prone sometimes, especially when they're distressed, that could lead to tilt them to suicidal thoughts and act. Now, access to means and methods does increase the risk of suicide. Lithium and clozapine are two important drugs in psychiatry which decreases the risk of suicide, which on long-term use, lithium and clozapine on long-term use decreases the risk of suicide, and that's been tested in exams as MCQs also. Please don't forget about it. Lithium and clozapine are two drugs which can decrease the risk of suicide. One last point I would like to add is ECTs are useful treatment strategy in suicide. Please understand, one of the most effective treatment strategies we have is ECTs and ketamine therapy. Ketamine therapy. Now, ketamine therapy is something which is now used by many of these specialized centers, where they use ketamine therapy to reduce the suicidal risk in patients. The only challenge with ketamine therapy is, once the effect of ketamine goes, or once you stop ketamine therapy, the patients do relapse with their suicidal ideas. So maybe you can buy some time, but it doesn't cure, or it doesn't kind of completely reduce the risk of suicide. You can just buy the time. And why should you buy the time? Because you need to understand, antidepressants take 2-3 weeks to work. So that 2-3 weeks of buying time might be necessary, and that's where the role of ketamine therapy can come in. Understood? So that's something which we should know. With this, I think in this video, where we have taken heterogeneous group of questions, what I've tried to do is to try to highlight some really practical, simple questions to some things which come in exam, to some interesting things which you might have never read about to understand. The aim is to increase your interest and understanding about psychiatry, and hopefully we will meet you in further videos and discuss a lot more things. Thank you very much.